Hello everyone, I am myself Dr. 𝗪𝐺𝐸𝐽𝐸. I am the general medicine educator. So in this session, I'll be discussing a very important topic in the ECG, that is the abnormalities related to the ST segment. So first of all, let me tell you what exactly is your ST segment. So ST segment, it is an isoelectric baseline. And this ST segment, which is an isoelectric baseline, it is the one which is present from the end of the S wave. So this is the S wave. So it is present from the end of the S wave to the beginning of the T wave. This is what is nothing but your ST segment, which is an isoelectric baseline. Now the point which is present at the end of the S wave and the starting of the ST segment, this is what is called as the J point. Okay, so J point, it is the end of the S wave, and the beginning of the ST segment is what is nothing but your J point. Now this ST segment, it is the one which represents the interval between it represents the interval between the ventricular depolarization and ventricular repolarization. Okay, so the ventricular depolarization is represented by the QRS complex, and ventricular repolarization is represented by the T wave. So between the QRS complex and as well as the T wave, that is what is your ST segment, okay, which is an isoelectric baseline. Now, whenever you come across this particular terminology ST segment, the first thing that comes into your mind is the ST segment elevation that might be contributing to the development of MI. Now, you need to be very much aware of like what should be the minimum ST segment elevation in the ECG leads to consider it as the myocardial infarction. You see a question here. So, how much should be the minimum ST segment elevation in limb leads for considering myocardial infarction? First option more than 2 mm, second option more than 1 mm, third less than 1 mm, fourth option more than 1.5 mm. So, to consider it as the ST segment elevation MI, what you have to remember is in the limb leads, in the limb leads, the ST segment elevation should be more than 1 mm, whereas in the chest leads, okay, so chest leads, they are like from V1 to V6. In chest leads, the ST segment elevation should be there more than 2 mm. So this more than 1 mm in the limb leads and more than 2 mm in the chest leads, that should be there in the contiguous minimum 2 leads. What do you mean by the word contiguous minimum 2 leads? For example, you take the inferior wall MI. What are the inferior leads? The inferior leads are 2, 3 and as well as the AVF. Now, to consider it as inferior wall MI, at least in lead 2 and as well as lead 3, there should be ST segment elevation. It can be more than 2 also, but minimum 2 leads, there should be ST segment elevation, contiguous. Like for example, like lead 3 and AVF, the ST segment elevation is there more than 1 mm. That is very much suggestive of your inferior wall MI. Okay, so this is like the importance of the ST segment elevation. But what you have to remember is the ST segment elevation is not just present only in cases of the myocardial infarction. There are many other conditions where you can have ST segment elevation. Now let me discuss and let me show you the ECGs of all other conditions. And regarding the ST segment, what are the abnormalities that we will be discussing is, we will be discussing the conditions where you have ST segment elevation, and we will be discussing the conditions where there is ST segment depression. These are the two abnormalities related to the ST segment is what we will be discussing. So, right. Now you see this question. ST segment elevation is seen in all of the following conditions except, the options are myocardial infarction, coronary artery spasm, constrictive pericarditis, the ventricular aneurysm. Okay. But if you observe this ECG here also you are having the ST segment elevation. And you know what is this shape of the ST segment elevation which is being described as? So if you observe the ST segment, it is called, or it is described as a tomb shaped ST segment elevation. Right, it is being described as a tomb shaped ST segment elevation. Now what are the conditions where you have the tomb shaped ST segment elevation? You have that in case of the ventricular aneurysm, and this ventricular aneurysm, it is secondary to the anterior wall MI. Right, secondary to anterior wall MI, there can be a tomb shaped ST segment elevation. Now let me tell you all the conditions where you have the presence of the ST segment elevation. Now, so you can just remember this mnemonic elevation as a mnemonic for the causes of ST segment elevation. The word E, it stands for electrolyte disturbances. Right? And what are these electrolyte disturbances? These electrolyte disturbances includes hyperkalemia, that is one of the cause for the ST segment elevation. Next, the word L stands for left bundle branch block. Even in patients with LBBB, you will have ST segment elevation. And the word E next, it stands for early repolarization syndrome, which is also called as the benign early repolarization. So early repolarization syndrome, which is also called as the benign early repolarization. And the word V, it stands for the ventricular aneurysm. Right? And the word T, it stands for trauma. And what is that particular trauma? This trauma to the chest or trauma to the pericardium in the form of pericardiocentesis. Right, in the form of pericardiocentesis. So in patients with cardiac tamponade, like we do pericardiocentesis by inserting the needle in the subxiphoid process, all right, or beneath the subxiphoid area, we insert the needle and enter the needle or pierce the needle into the pericardial space, right, and taking out that particular fluid is what is called as the pericardiocentesis. So if there is any injury to the myocardium when you are doing pericardiocentesis, there can be ST segment elevation within the ECG. And the word I, it stands for the ischemia, right? And this ischemia, it includes the coronary artery disease, and this ischemia, that is in case of the myocardial infarction. And the word O stands for the Osborn wave. Now what is the condition where you have the presence of the Osborn wave? The Osborn wave is seen in cases of the hypothermia. In hypothermia, you come across this Osborn wave. So in patients with hypothermia also, you have the presence of ST segment elevation, right? I'll be showing you that Osborn wave and as well as ST segment elevation of hypothermia parallelly. And the word N stands for non-occlusive vasospasm. Now, what are the conditions where you have non-occlusive vasospasm? Non-occlusive vasospasm is seen in case of vasospastic angina, which is also called as the Prinzmetal angina, right, which is also called as the Prinzmetal angina. Okay, so in Prinzmetal angina, even though there is no atherosclerosis, there can be coronary vasospasm causing reduced blood supply to the myocardium causing ST segment elevation. And the word A stands for acute pericarditis. Right? Acute pericarditis. And the word B, it stands for Brugada syndrome. So in Brugada syndrome, it is actually a form of the sodium channelopathy. It is a disorder related to the sodium channels. And in these patients with the Brugada syndrome, there is chance of development of VT or VF causing sudden cardiac death, right? And you have that classical saddle-shaped ST segment elevation in patients with the Brugada syndrome, and I'll be discussing that ECG as well. So these are all the conditions where you have the presence of ST segment elevation. So it is not just only in case of MI. Multiple conditions you have ST segment elevation, and I will show you all these ECGs now. So first, yes. So you see this question. We have a 70-year male, known case of diabetes mellitus and CKD stage 5. This patient presented with history of dyspnea. ECG shows as follows. And what is the diagnosis? The hypokalemia, hyperkalemia, hyponatremia, and hypercalcemia. So what is that you need to know from the clinical scenario? First of all is the patient is in CKD stage 5. And in CKD stage 5, what are all the electrolyte abnormalities that can be seen? The electrolyte abnormalities that can be seen in patients with CKD stage 5 will be the hyperkalemia, then hypocalcemia will be there. That is because of your vitamin D deficiency, right? And these patients, they can also have the hyponatremia, and that is because of your dilution as well, okay? Right. But whatever the ECG changes that you are observing, that is the presence of tall tented T waves. Along with tall tented T waves, you are also able to observe the ST segment elevation, right? You are also able to observe the ST segment elevation. So tall tented T wave with ST segment elevation, that is very much suggestive of the hyperkalemia, right? That is very much suggestive of hyperkalemia. So the ECG which is being given to you here is the ECG of the hyperkalemia. So in hyperkalemia also you have ST segment elevation. Now at this point, let me tell you what are all the various ECG changes that you come across in hyperkalemia and what are all the various ECG changes in patients with hypokalemia. Okay. Anyways, I have shown you the ECG of hyperkalemia. First, let me discuss the ECG changes of hypo, and again I will come back to the hyper. Okay. So the question can be, right, you see this question, which among the following is not the ECG findings of the hypokalemia? The options are the short PR interval, T wave flattening and inversion, ST segment depression, and prominent U wave. Okay, so among the options which has been given to you, the one that you don't see in patients with hypokalemia is short PR interval will not be there. In patients with hypokalemia, you will have a prolonged PR interval. Now, let me tell you at this point what are all the various ECG changes that you come across in patients with the hypokalemia. So, now the effect of hypokalemia on the ECG. Number one, the earliest changes that you come across in patients with hypokalemia ECG will be usually when the potassium levels, like they are less than 3 milliequivalents per liter, that is the point when the ECG changes will start appearing. And these ECG changes include the appearance of the U wave. In a normal individual, you don't have a U wave. There are some rare physiological causes, but the first important thing will be the appearance of the U wave, and the T wave, it becomes inverted or flat. So these are the early ECG changes that you come across in patients with the hypokalemia. Then followed by these two, if you take the ST segment. In patients with hyperkalemia, we have discussed that there is ST segment elevation. Exactly contrary to that, in patients with hypokalemia, you have the ST segment depression. Okay. And what will happen to the QT interval? The QT interval, which is like starting from Q wave, the end of up to the end of the T wave, the QT interval will be prolonged, right? So there are three important electrolyte abnormalities where you have QT interval prolongation. One is hypokalemia, second one is hypomagnesemia, and third one is hypocalcemia. These are the three important electrolyte abnormalities where you have the presence of QT interval prolongation. And the fourth important ECG change in patients with hypokalemia will be the PR interval prolongation. So QT interval and as well as the PR interval, both of them, they are like prolonged. And what will happen to the P wave? Lastly, the amplitude of the P wave, right, the amplitude of the P wave, it is increased, right, the amplitude of the P wave is increased, and the amplitude of the P wave which is increased, this we call it as P pulmonale, right, this we call it as P pulmonale. But usually you come across this P pulmonale in patients with right atrial hypertrophy. But here you don't have right atrial hypertrophy, but still the amplitude of the P wave is increased. And that is the reason why this is called as pseudo P pulmonale, right, where the amplitude of the P wave, right, where the amplitude of the P wave will be more than 2.5 mm. So these are the ECG changes that you come across in patients with the hypokalemia. Let me show you the ECG as well. Now, this is the ECG of the hypokalemia. Right, this is the ECG of hypokalemia. So let me just try to show you all the waves that we have discussed. So now this is lead 2, which is considered as rhythm strip, and in the rhythm strip you will be able to observe all these changes what we have discussed. So this will be your U wave, right? Then followed by that, this is your T wave inversion, right? T wave inversion. Okay, either it might be flat T wave or the T wave being inverted next. And then followed by that, you take the QT interval, or we consider it as actually QU interval, because your T wave is merged with the U wave, so you have to take the QT interval up to the end of the U wave. So QT interval, that will be prolonged. Okay, so these are the changes that you are having here. And as the severity of the hypokalemia increases, what will happen? The ECG changes related to severe form of hypokalemia will also observe, which is nothing but the prolongation of your PR interval and as well as the pseudo P pulmonale. Now, if you observe the ECG changes that you have in patients with the hyperkalemia, see, whenever there is hyperkalemia, what exactly is that? It is like increase in the, right, it is increased extracellular potassium levels, right, it is increased extracellular potassium levels. Now this increased extracellular potassium, it reduces the myocardial excitability, right, it reduces the myocardial excitability. Now, so once there is reduction in the myocardial excitability, that will result in reduction in both the pacemaker activity of your myocardial cell, and that will also cause reduction in the conduction within the cardiac muscle. Okay, so because of decreased conduction and because of decreased pacemaker activity because of hyperkalemia, what happens is, like, there is suppression of the impulse generation, right, suppression of the impulse generation by the SA node, right, by the SA node. Okay, and thereby there is reduced conduction across the AV node. Right, thereby there is reduced conduction across the AV node, and this will result in bradycardia, this will result in the conduction block, this will result in cardiac arrest. Okay, so this will be the effect of hyperkalemia on the heart. Now, you see this question, which among the following is not the ECG finding of hyperkalemia? Wide P wave and flattening of the P wave, PR segment lengthen, P wave disappear, narrow QRS interval. So the one what you don't see in your hyperkalemia is the narrow QRS interval will not be there. So in fact, you will have wide QRS interval. Now, let me tell you all the ECG changes of the hyperkalemia. Two changes I have discussed. One is your tall tented T wave, and then we have discussed that there is ST segment elevation. And when do you call hyperkalemia? When the potassium levels, like when they are more than 5.5 milliequivalents per liter, then we use the word hyperkalemia. Now, the ECG changes completely depends upon the severity of hyperkalemia, right? When the potassium levels are more than 6, it is called moderate hyperkalemia, right? If it is more than 6, we call it as moderate form of the hyperkalemia. And if the potassium levels more than 7, then it is considered as the severe form of the hyperkalemia, right? It is considered as severe form of hyperkalemia. And when the potassium levels are like more than 5.5 milliequivalents per liter, that is the point when you have the appearance of the ECG changes. Now, what are all those? So, the ECG changes that you will have is, number one, tall tented T wave, right? Then you will notice that the ST segment will be elevated, and you take the QRS complex. You have wide QRS complex, right? You have wide QRS complex, and followed by that wide QRS complex, and you take the P wave. What will happen to the P wave? The P wave, it becomes flat and as well as wide. You see this. The P wave, it becomes flat and as well as wide. And at one point of time, there is no P wave. The P wave disappears, right? And what will happen to your PR segment? The PR segment is like from the end of the P wave to the starting of the R wave. That is called PR segment. So PR segment, it widens. The PR segment, it widens. Okay. So these will be the ECG changes that you will have in patients with the hyperkalemia, right? Now, after having discussed about, okay, this wave, because of hyperkalemia, this we call it as the sine wave pattern. Right, this we call it as sine wave pattern, where there will be like disappearance of your P wave. The P wave will be completely flat and completely disappears, and then you have wide QRS complex, and yeah, so you can see this. So this is what is your classical sine wave pattern. All right. Now, at one point of time, like what did I tell you, in very severe form of hyperkalemia, these patients, they will develop bradycardia, and finally they progress to the cardiac arrest, right? So these will be the ECG changes in patients with the hyperkalemia. Now, after having discussed about the ECG changes in hyper and hypokalemia, actually we are discussing the concept of the ST segment. Hyperkalemia is one condition where you have the presence of ST segment elevation. Then, yes, you see the other question. 46-year male presents with history of chest pain since 2 hours. ECG is as follows. What is this ECG suggestive of? Right ventricular MI, left bundle branch block, right bundle branch block, the posterior wall MI. Okay, so this particular ECG I have discussed when I was discussing the QRS complex. Okay, now if you observe the QRS complexes in these patients, what is that you are observing? The abnormality is there is wide QRS complex. If you take the QRS interval there, right? The QRS interval is like more than 120 milliseconds. Now, along with wide QRS complex, what is that you are observing also, right? You are also observing the presence of the ST segment elevation, right? You are also observing the presence of the ST segment elevation. So wide QRS complex and as well as the ST segment elevation. And along with that, if you take the pattern of the if you take the pattern of the wide QRS complex, so you are having deep and wide QRS complex in V1, right? Deep S wave in V1, and you take the R wave. How is the R wave in V6? It is broad, tall R wave in V6, right? Broad, tall R wave in V6. So this is suggestive of your left bundle branch block, right? This is suggestive of left bundle branch block. Now let me tell you the concept of left bundle branch block. See, in patients with the left bundle branch block, your left bundle branch which is supplying to the LV myocardium is like blocked. So once the left bundle branch block which is supplying to the myocardium is blocked, which is the chamber which will get depolarized first? It is the right ventricle which will get depolarized first. Okay, it's the right ventricle which will get depolarized first. And where are your electrodes being present? So this is your V1 and this is your V2, V3, V4 and V5 and V6. So if you observe, the electrical activity is towards the right ventricle first. That means it is like away from your V3, V4, V5, V6. The electrical activity is like away. The vector is moving from right to the left because your right ventricle is getting depolarized first. Okay. After the right ventricle, the left ventricle will depolarize later. That is second. So the vector is moving from right to left. So the complex will be negative in V1 and V2. So in V1, the complex will be negative because the vector is moving away from V1 and the vector is moving towards your V6. So that is the reason why you have tall R wave. Now the question comes, why the S wave in V1 is like broad and why the R wave in V6 is also broad? That is because of your bundle branch block. Normally what should happen is both ventricles, they should depolarize simultaneously, right? Both ventricles, they should depolarize simultaneously. All right. When both ventricles are depolarizing simultaneously, the duration of the QRS complex will be around 70 to 100 milliseconds. But here what is happening? The right ventricle is depolarizing first. After the right ventricular depolarization, left ventricle gets depolarized later. Okay, it is the second, the left ventricle which will get depolarized. Okay, now because both the ventricles are not depolarizing simultaneously, the depolarization is happening one after the other, right? Depolarization is happening one after the other. That is the reason why you have the presence of the wide QRS complex. Right, that is the reason why you have the presence of wide QRS complex. Okay, so this is the concept of your LBVB. Now at the same time, you should know like what are the causes of the left bundle branch block. So if you see the causes of left bundle branch block, just remember this mnemonic, that is A2, D2 and as well as the H2. A2 stands for the aortic stenosis and then the anterior wall MI, and D2 stands for the digoxin toxicity and dilated cardiomyopathy, so DCMP, and then digoxin toxicity, and the word last H2. The word H2 is your hypertension, right? And next hyperkalemia. right? Hypertension and as well as the hyperkalemia. So these are the causes of the left bundle branch block. All right. So in case of left bundle branch block, also you are having ST segment elevation. So previously, like what we have discussed, one of the electrolyte abnormality is hyperkalemia. Next, which bundle branch block you are having ST segment elevation? That is left bundle branch block. All right. Now, then you see the next question. Yeah. So ST segment elevation is seen in all of the following conditions except myocardial infarction, coronary artery spasm, constrictive pericarditis, and ventricular aneurysm. So, what you have to remember and understand is myocardial infarction, you will have ST segment elevation. Coronary artery spasm, you have ST segment elevation, which is nothing but your Prinzmetal angina. And ventricular aneurysm, also you have ST segment elevation, and that we call it as a tomb-shaped ST segment elevation. But the ST segment elevation is not observed in case of the constrictive pericarditis. Whereas, if you see in case of the acute pericarditis, in acute pericarditis, right, in acute pericarditis, you have the presence of ST segment elevation, but not in case of the constrictive pericarditis. In constrictive pericarditis, what is that you will observe is the presence of low voltage complexes. Right, presence of low voltage complexes. So low voltage complexes are observed in patients with the constrictive pericarditis, pericardial effusion, and even cardiac tamponade also. I have discussed about low voltage complexes in the topic of the QRS complex. You can refer back to that, okay? But in constrictive pericarditis, you don't have ST segment elevation. What is that you have is low voltage complexes. But in acute pericarditis, you have the presence of ST segment elevation. I'll be showing you that ECG as well. So, right. So, if you see the next question, right. So, a 72-year patient presents with the chest pain since 4 days. Pain is increasing on applying the minimal pressure over the precordium. He came for routine evaluation. His ECG is as follows, like what is the diagnosis? The options are the anterior wall MI, inferior wall MI, benign early repolarization, lateral wall MI. See, this particular patient is having the chest pain since almost 4 days, right? Since 4 days. And the pain, it is increasing on applying the pressure, right? On applying the minimal pressure over the precordium. So he came for routine evaluation. So if you observe the ECG changes here, you are able to notice that there is ST segment elevation in V2, V3 and as well as V4. That is in the precordial leads. So if there is ST segment elevation in the precordial leads, like let us just assume, for example, if we are considering it as an anterior wall MI, right? What should be there in anterior wall MI is, along with ST segment elevation in your precordial leads, there should be also reciprocal changes. I'll show you what is that reciprocal changes. So reciprocal changes should be there within the inferior leads, right? That is your 2-3 AVF. In 2-3 AVF, there should be ST segment depression should be there. But in this ECG, if you observe, you are not having the ST segment depression. So that is the reason why this is not suggestive of the anterior wall MI. Then what is this suggestive of? This is suggestive of the benign early repolarization or your early repolarization syndrome. Now, let me tell you few points about your benign early repolarization. So, if you take this benign early repolarization, this is the one which will produce widespread ST segment elevation. And where do you have this widespread ST segment elevation? Mainly in the precordial leads in case of benign early repolarization. And what will be that precordial leads? These precordial leads will be from like V2 to V2, V3, V4. You have the ST segment elevation in benign early repolarization. And this benign early repolarization, it is present in almost 10 to 15% of patients whoever are coming to emergency department presenting with history of chest pain. And what exactly is the physiological basis for the ST segment elevation in case of benign early repolarization is not known, right? And but it is considered as a normal variant. It is not a pathological condition. It is a normal variant. That is very important point you need to know, right? And it is not indicative of an underlying cardiac disease, right? It is not indicative of an underlying cardiac disease, okay? And this benign early repolarization is less common in over 50s. This is very common in the young individuals of age around 30 to 40 years or 30 to less than 50 years. You have this benign early repolarization. So how to recognize this benign early repolarization? You have the ST segment elevation in V2 to V4, or okay, even up to V2 to V5, right? And within this ST segment elevation, you will notice that there is slurring, upward slurring of the J point, right? Upward slurring of the J point, okay? And the T wave that you will observe here is the asymmetrical T wave. It is not symmetrical T wave. It is asymmetrical T wave that you will observe. I'll show you that particular T wave as well. And what is very important is you will not have reciprocal changes, or there is no reciprocal ST segment depression in the inferior leads. Right, there is no reciprocal ST segment depression in the inferior leads. So this is suggestive of the benign early repolarization. And the ST segment elevation, whatever you're observing, they're usually less than 2 mm. Okay, they're usually less than 2 mm in the precordial leads, right? Or it could be less than 0.5 mm if at all, if they are present in the limb leads. Usually in the limb leads you don't have. If at all, if there is ST segment elevation in the limb leads, it will be less than 0.5 mm, okay? And now, how will you differentiate ST segment elevation from the benign early repolarization is one important point, you don't have the reciprocal changes. And second important point, how will you differentiate it from the ST segment elevation is there will be no dynamic changes. That means there is no progression of the ST segment changes in patients with no progression, or there will be no dynamic ECG changes. Okay, so what do you mean by the word there is no dynamic ECG changes? Means the ST segment which is elevated, that will remain stable. So it is like stable ST segment elevation. You don't have the dynamic ECG changes. Right. So this is about the discussion related to benign early repolarization. In the precordial leads, less than 2 mm ST segment elevation, stable ST segment elevation. You don't have, right? You don't have the dynamic changes, right? And if at all in the limb leads, it should be like less than 0.5 mm ST segment elevation should be there, and there will be no reciprocal changes in the inferior leads if there is ST segment elevation in the precordial leads. Okay. Now, let me try to show you the ECG of reciprocal changes of anterior wall MI. Right. So, if you observe the ECG changes here, in this, like you are having ST segment elevation in V2, V3, V4, right? And the ST segment elevation, it is definitely more than 2 mm. And along with that, if you observe, there is like ST segment depression in lead 3, right? And a very minimal or absent, okay. But in lead 3, you are having the ST segment depression. And the ST segment depression, whichever is there, in response to that ST segment elevation in the anterior leads, that is what is nothing but your reciprocal changes. And as the time passes, like in these patients with the ST segment elevation MI, the ECG changes also differs. What will be the change in the ECG? What is the dynamic changes you get in patients with MI? So that includes the following. So Actually, the earliest ECG change in patients with MI, right? The earliest ECG change in patients with MI is not ST segment elevation. It is broad tall T wave. Okay, so broad tall T wave, it is the earliest ECG change in patients with the MI. Then followed by that you have ST segment elevation. Followed by that you have the disappearance of the R wave and appearance of the Q wave, right? And later you will notice that your T wave is being inverted, and at one point of time all the changes will disappear, right? At one point of time all the changes will disappear. There will be presence of only Q wave. And where is that you have persistent tomb shaped ST segment elevation? You get this in patients with the ventricular aneurysm. That is what I have shown you in the beginning of this particular session also. Tomb shaped ST segment elevation is very much suggestive of your ventricular aneurysm, and the tomb shaped ST segment elevation does not change immediately. Okay, so this is about the ECG changes that you have in patient, dynamic ECG changes in patients with your MI. Whereas in patients with the benign early repolarization, you don't have the dynamic changes, right? Broad tall T wave, ST segment elevation, disappearance of R wave, appearance of the Q wave, T wave being inverted, and at one point of time all the ECG changes disappear, only Q wave will be there. That will not be there in case of benign early repolarization. That is what I have said you, that there is no dynamic changes in patients with the benign early repolarization. Okay, so we have discussed hyperkalemia as one of the cause for ST segment elevation, left bundle branch block as one of the cause for ST segment elevation, benign early repolarization as one of the cause for ST segment elevation. Then you see the next question. Okay, 68-year male presented with the chest pain since almost 2 hours. Patient was taken for the primary PCI, coronary angiogram was done, which will show a block, right? Coronary angiogram shows the block in which vessel. So this is the ECG of the patient. The options are right coronary artery and left circumflex artery, the left anterior descending artery and left circumflex artery, only left anterior descending artery, only left circumflex artery. Okay, so now you're having the ST segment elevation in the anterior leads. You're also having the ST segment elevation in the lateral leads as well. That is 1 AVL V5 V6 also you're having ST segment elevation, and along with that in lead 3 if you observe there is ST segment depression. So this is definitely right. So this is definitely suggestive of the ST segment elevation MI. There's no doubt in that. So you have the changes in the anterior leads and you have the changes in the lateral leads as well. So the block is present in the left anterior descending artery and as well as the left circumflex artery as well. So this is the ECG suggestive of your myocardial infarction. And what MI is this? It is anterolateral MI, right? Anterolateral MI. And in these patients, what will be the immediate treatment or immediate best treatment? The immediate, actually, what will be the first line treatment in these patients? The first line treatment in this patient is you need to give antiplatelets, that is aspirin should be given, right? And aspirin 325 milligrams bolus should be given, okay? Oral, chewable. And what is the best method of revascularization in this patient? Because he presented within 2 hours, right? The best method of revascularization will be in the form of PCI, that is percutaneous coronary intervention. Okay, so this is about the ECG changes of ST segment elevation in patients with the myocardial infarction. All right, next question. So until now, like we have discussed ECG changes of ST segment elevation in hyperkalemia, left bundle branch block, benign early repolarization, and then the ST segment elevation MI, right? So 52-year female patient presented with the chest pain since almost 1 hour. What is the best management in this patient? The only DAPT, thrombolytic therapy, primary PCI, statins. So chest pain is there since 1 hour. First of all, let us try to crack the diagnosis. So this patient is having the ST segment elevation in 2, 3 and as well as the AVF, right? So the presence of ST segment elevation in 2, 3 AVF is very much suggestive of the inferior wall MI, right? It is very much suggestive of the inferior wall MI. So what is the best management? Only DAPT, thrombolytic therapy, primary PCI, statins. So this particular patient also presented within the golden period of your treatment of MI. So this patient also should be offered the primary PCI as the first important or best method of the revascularization.